Good afternoon. We are now entering our second abstract competition. These will be 4 presenters, 7 minutes each, 3-minute discussion each. You will recall that we received over 100 abstracts submitted, and we selected through the program committee, actually numerous people on the committee and board judged these abstracts, and we selected the top 8. 4 of them were presented yesterday, and Dr. Kim from South Korea won that competition. Today we will hear 4 more excellent presentations, and we will choose one winner from today. The first speaker is Maria Comenici from the UK, and the title of her abstract is Long-Term Survival and Predictors of Mortality After Off-Pump and On-Pump Coronary Artery Bypass Grafting, a 25-year follow-up study.
Good afternoon, everyone. First of all, I would like to thank the Society for the opportunity to present our work. And my presentation today is a 25-year follow-up study comparing on-pump and off-pump CABG. The debate between on-pump and off-pump, The debate between on-pump and off-pump CABG has been going for decades. We debated the subject a bit more during these days. However, there seems to be no universal or final answer to this debate. We heard in Mr. Raja's presentation yesterday, initially off-pump emerged as a potential solution to all the issues that the cardiopulmonary bypass machine carries. However, off-pump couldn't prove itself through different studies and trials, and one of the main factors for this was the low level of experience of the surgeons that performed these operations. Off-pump is indeed technically demanding and requires a high degree of expertise. One of the most important outcomes for any procedure remains long-term survival, and a meta-analysis published in 2017 showed that off-pump performed worse at 10 years, and it was associated with higher rates of mortality at 10 years. Some studies that followed that publication showed no difference in mortality at 10 years, and an updated meta-analysis in 2024 showed that off-pump indeed can deliver similar 10-year survival rates to on-pump CABG. We decided to look at our experience as a high-volume center of off-pump procedures, and we retrospectively analyzed the outcomes of our patients who underwent a CABG between 1996 and 2023. Almost 14,000 patients were included, 54% of which were on off-pump procedures. We employed propensity score matching, which resulted in 5,684 pairs. I'll just mention that we only looked at long-term mortality and did not report any other outcomes in this analysis. We matched the patients for all preoperative covariates, and the groups were well balanced, with no significant differences in terms of preoperative characteristics. In terms of intraoperative features, the patients in the on-pump group received more total arterial grafting, and we can also see relatively low rates of conversion of off-pump to on-pump, roughly 1.8%, which is a reflection of the high level of expertise of the surgeons that perform these procedures. Our long-term survival analysis showed excellent results. Off-pump was associated with higher rates of survival when compared to on-pump at 25 years, with significant p-value. In our multivariate analysis, off-pump was also independently associated with lower risk of mortality and therefore higher survival. These results were consistent in different subgroup analyses. Here we showed all-cause mortality in low-risk patients, high-risk patients, and patients with left main stem disease. In all these analyses, off-pump was associated with better survival. Taking it a step further, we performed an interaction analysis to understand whether the effect of surgical technique off pump or on pump on long survival is influenced by the grafts that were used. In this type of analysis can help us understand, for example, whether using multi-arterial grafting works better with off-pump or with on-pump, and helps identify if certain combinations perform better than others. Our analysis showed that off-pump CABG with single and multiple arterial grafting was associated with lower rates of mortality, while on-pump with single arterial grafting had the highest mortality. When focusing on the group that had total arterial grafting, the analysis revealed no significant differences at 25-year, and perhaps it suggests that optimal grafting strategies, such as total arterial grafting, has better or higher influence, and the choice of the surgical technique has less influence in this case. The natural question that arises after seeing these results is why and how our institution achieved such good results. First of all, we can remind ourselves that avoiding cardiopulmonary bypass machine indeed carries benefits: less systemic inflammatory response, less organ dysfunction, less hemodilution, less aortic manipulation, and ultimately we don't quite understand yet the long-term effects of the cardiopulmonary bypass machine. Importantly, it's worth mentioning that our surgeons are highly experienced surgeons, and those that do off-pump, 99% of their operations are indeed off-pump, and this was evident by the low rate of conversion of off-pump to on-pump showed earlier. Thirdly, as equally as important, at Harefield we have a strong protocol that we follow in terms of secondary preventions. All our patients are started on a beta blocker, on a statin, on an ACE inhibitor. Additionally, all our off-pump patients are started on dual antiplatelet therapy, whereas things are a bit more variable for the on-pump cases, and quite a big proportion of those patients go home on only aspirin. So what does the findings of this study actually tell us? Should all patients have off-pump? Probably not. Should all surgeons be doing off-pump? Again, probably not. But what this study does show us is that when done by experienced hands, off-pump does not compromise the long-term survival. And Mr. Raja has very nicely presented the experience and the way they adopted and implemented the program at our hospital in this article. It's worth reading. Thank you for your attention.
Dr. Kamenichi, that's a terrific piece of work, and congratulations also, of course, to Dr. Raza for his leadership in this field. I'm relieved to know that at Harefield there's no negative impact on long-term survival from off-pump bypass. I'm not surprised to learn that multi-arterial grafting impacts long-term survival. And I think it's important to note that the likely benefit of off-pump bypass will be relatively early in a patient's perioperative period. It'll be around the time of surgery and shortly thereafter that OPCAB should outperform on-pump bypass when done well. But it's clear that it will only deliver the same long-term benefit as on-pump bypass if it is done well. So congratulations to Hereford.
Thank you.
That's a question.
Hi, Gabor from Belgium. What was the rationale in your center of putting the off-pump group on dual antiplatelet therapy?
I think it's again, it's protocol for, it's quite standardized at our hospital, but perhaps one of the reasons behind it is there's evidence that the off-pump is associated with a bit hypercoagulable state perioperatively. So I think this is one of the aspects why the patients are started on dual antiplatelets. Again, there's quite a bit of evidence supporting aspirin resistance, and that's quite common as well, perhaps which we don't actually acknowledge it enough, but it does impact the outcomes of our patients as well. And having these patients on dual antiplatelets offers a higher level of protection.
How long is it maintained?
Sorry?
How long is it maintained, the dual antiplatelet therapy?
Yes,
How
so
long?
dual antiplatelet for 1 year, and
1 year.
then aspirin lifelong.
Okay, thank you.
Thank you.
One last question from the crowd.
Thank you very much. I'm Ferdi Aksa from Eindhoven, the Netherlands. Amazing talk, amazing data. Congratulations on the data. And when you look at your 25-year result, you see 16% mortality difference. So maybe this should encourage us to make it coronary surgery a subspecialty. The effect is much more than even full arterial grafting compared to Lima to Stephanus vein graft, with 16% mortality difference. So congratulations, and I think we cannot go around making it subspecialty if this is the outcome that we get if performed by experienced surgeons.
Thank you. And that is what our team has been advocating for. Thank you.
Super.
Thank you.
So our next presentation is from Germany, and it's comparison of long-term clinical and angiographic outcomes of skeletonized versus pedicled internal thoracic artery harvesting technique, a propensity score match study by Dr. Abul Hassan. Thank you.
Thank you. Thank you. It's a great privilege to be here with you. Just to notify, I'm from Poland, from Nowa Sól, Poland. So those are my disclosures. Recent data regarding skeletonization and pedicle were conflicting, especially we all know this study from COMPASS trial by André Lamé, where they showed that skeletonization is associated with reduced graft patency at follow-up, where moreover MACEs were increased and repeated revascularization were increased in the skeletonized ITA. This is meta-analysis from Di Magli, where they compared the two, the pedicalization and skeletonization. As for mortality, there were no difference. However, patency rates were inferior in the skeletonization technique. So therefore, we aimed in our study to compare those two techniques. Between 2010 and 2022, 3,255 patients were analyzed. Out of those, 353 were excluded. So at the end, 2,909 patients were divided into two groups. Propensity score matching was performed into one-to-one fashion. Follow-up data were retrieved from the National Healthcare Registry and were available for all patients. 873 patients were registered with angiograms at follow-up. We were able to retrieve 87% of them. Long-term outcomes investigated were myocardial infarction, repeat revascularization, stroke, all-cause mortality, and MACE as composite outcomes, and graft patency. In the match cohort, median follow-up time was 6.7 years. We were able to have 961 pairs, Well-balanced pairs before matching, patients with pedicled ITA were more prone to have peripheral vascular disease, lower ejection fraction. However, in the skeletonized technique, more patients had multiple arterial grafting, around 27%, and more trainees were performed this technique, around 50%. After propensity score matching, the baseline characteristic as well as operative were well balanced. So early outcomes, there was lower incidence of sternal wound infection in the skeletonization technique by around 67%. As for the long-term outcomes, in terms of survival, the survival was comparable between both groups at 10 years. Freedom from myocardial infarction was comparable between both groups at 10 years. Freedom from repeat revascularization was comparable between both groups at 10 years. Stroke comparable, and MACEs at 10 years were comparable between both techniques. So as for the angiography, median follow-up time to angiography was 3.7 years with a cardiac CT or coronary angiography. Of the 767 patients, 50% of them had skeletonized ITA. ITA patency was in general comparable between both groups. LITA as well as RITA patency was also comparable between both groups. So it's a single center study, non-randomized, and for sure we need randomized control trials. I think the HARVITA trial will give us more information in the future. So in conclusion, compared to pedicled ITA, skeletonized ITA is associated with lower risk of deep sternal wound infection, comparable graft patency, comparable long-term survival, MI, repeat revascularization, stroke, and MACE. Thank you.
Thank you for that very nice presentation. And one of the things that I think your data has brought out is when you look at Dr. Lamy's paper on skeletonization, there was no reference to the expertise of the people who were harvesting the pedicle or who were skeletonizing. But if I understood you correctly, you're saying that for your study, those were propensity matched.
Yeah. So in our center, mainly half of our surgeons, including me, perform skeletonization. When I was doing this study, I was a trainee, so my colleagues were teaching me this technique. However, the second half of the surgeons do only pedicles, so we were quite divided, and we routinely do, those who do, they do it routinely.
Well, that's a major strength of your presentation. Just one other question, if I may. I know, did you routinely do TTFM measurements in the operating room?
So we are doing routinely for the past 4 years. In
But
this study, only 2 years of them, they were doing TTFM, the studies before, no.
And within that 2 years, because you've
Yeah.
got 900 patients, which is
961 patients.
patients. So in those 2 years where they were doing TTFM, was there any difference at the end of the operation in flow rates between the skeletonized and the non-skeletonized? Do you know?
Yeah, well, I did a small analysis for the past year. The mean flow was higher in the skeletonized ITA, whereas the PI was similar.
Thank you.
Dr. Volk, any comment?
Yeah, I was just interested in, if you look at your 3-year follow-up data in terms of patency rates, are they comparable to what's been reported in the literature for the most recent trials? I mean, we have a couple of trials where we do have angiographic follow-up data at 3 years. Is that in the same range?
I think, yeah, it's around 90%. It's median follow-up, so 3 years. There was a range between from 2 to 10 years. In our study, the patency rate. So,
Gianluca?
Great presentation and very well done. Which energy source did you use to skeletonize your IPA?
low electrocautery.
Which setup? How much you put
Around 19, 18, 19, yeah.
Any questions from the audience? One more, final one, please. Thank you.
Yeah, aside from surgeon skill, I think there's a lot of difference between using a radiofrequency ablation, radiofrequency and harmonic scalpel. But the question is always the $400 difference in price.
Thank you. On that point, thank you for your presentation. Excellent presentation.
Super. Our next speaker, again emphasizing the international nature of our organization, is from Tokyo. A long-term outcome of off-pump coronary artery bypass grafting using only in situ 3 arteriographs. Hiroshi Ninami.
Yeah. Thank you very much, and I'm really honored to be here. This is my COI. The object of this study was to evaluate long-term clinical outcome in patients who underwent complete arterial revascularization, only using 3 in situ arterial grafts, bilateral ITS and GA, in triple vessel disease patients. In this study, all patients were operated under off-pump condition, and all 3 grafts were harvested as skeletonization fashion with a harmonic scalpel. Major exclusion criteria to use GEA was diameter less than 2 millimeter and target coronary stenosis less than 90%. This slide shows patient selection. During the study period, just 1,800 patients were operated. About 1,200 patients were triple vessel disease patients, and 98% were performed op-cap. In this, about 30% patients were operated using only in situ bilateral ITA and GA. Patient characteristics were shown in this slide. As you can see, there was not much difference between the bilateral ITA and GA group and others. However, this slide shows the difference between 2 groups, which indicate that there was a trend towards less severe disease in patients with bilateral ITA and GA group compared to the other group. The primary endpoint was all cause of death, and the secondary outcome was MACE. This diagram shows my standard graft arrangement with in situ bilateral ITA and GA. The technical advantage of this arrangement are as follows. Aortic no-touch must be big advantage. And the last one means that unlike the composite grafting method, territory of each graft is perfused separately for risk hedge in case of the graft problem in the future. Right ITA was mainly used for LAD, and the left ITA was used for circumflex. GA is all used for distal right coronary arteries. To be able to perform complete revascularization with only in situ arterial grafts, sequential bypass technique is essential, especially for circumflex branches. This is an example post-op angio of leader to circumflex sequential bypass. This is a post-op angio of GA to distal RC sequential bypass. This also post-op angio by CT image. Average number of distal anastomosis was 4. Intraoperative TTFM assessment was performed for all grafts in all patients. Early graft patency rate was close to 99%. SSI, surgical site infection, occurred in 6 patients, but these were superficial wound problems and there was no median stenitis. Since the introduction of the standard plate in Japan in 2013, we have been using this for all patients, And this maneuver helps to avoid median stenosis, I believe. Post-operative mortality was 0. This slide shows the long-term result of overall survival and the MACE. Overall survival in 10 years was 85%, and the MACE-free survival in 10 years was 80%. Cardiac death-free survival in long term was also quite good, as well as cerebral infarction-free survival and the PCI-free survival. Univariable analysis showed that CKD, including hemodialysis and diabetes, were no longer associated with survival, whereas only age was predictor for survival. Overall survival during follow-up in patients younger than 60 years versus patients 60 years or older at the time of surgery shows difference, but not in patients in diabetes. Same as MACE-free survival. So several studies on CABG with only in situ 3 arterial grafts have been published. The present study was slightly worse overall survival result than the other studies. However, this is mainly due to the older age of the patient in this study than other studies. All but the present study were in the 50s at the time of surgery. MACE-free survival in the present study seems to show better results than other studies. The reason for this could be the difference in graft harvesting method, skeletonized fashion, and off-pump CABG. So, in conclusion, the long-term result of OPCAB with only in situ bilateral ITA and GA were excellent, with a higher survival rate and lower MACE incidence. Complete revascularization using skeletonized bilateral ITA and the super-skeletonized GA harvesting may improve the long-term survival and the incidence of MACE. The indication of OPCAB with in situ skeletonized bilateral ITA and super-skeletonized GA can be extended more for patients with triple vessel disease. Thank you very much for your attention.
Hiroshi, that's a tour de force technically. All arterial, no aortic touch bypass without using the radial artery, but rather using the gastroepiploic. 3 inflows, 3 to 5 outflows, and no mortality at 30 days in 350 patients. Congratulations, that's a lot. Really good.
Thank you.
How are we going to get the rest of us to learn how to do that? How adoptable is this technique by other surgeons? How do you teach it in Tokyo?
Actually, my mentor, Professor Endo, started like 30 years ago in Tokyo, my center, and then that time he used only the standard technique, conventional way, using this technique. But that time it bleeded a lot. Asian tend to bleed a lot. So I thought, it's better to use the off-pump technique. So that's why I started slowly. But then that's why only the 30% patient of the triple vessel disease we do this way. But because I slowly started the low-risk patient. But now maybe I do like more than 50% of these patients for triple vessel disease. So.
And what advantage do you see to the GEA compared to the radial artery?
Yeah, that's a big discussion because in Japan, the radial usage is much, much lower than the Western countries, only 5%. But even the GEA, 7%. But as I shown the video a couple of days ago in this conference, I don't know for the Western country people, but the Asian people tend to have a big GEA. So, and that's probably, I don't have any scientific evidence, but maybe we use much stomach compared to the Western people. That's why I keep saying to eat sushi.
Is it the benefit of a fish diet?
I don't know the fish, but we eat lots of the rice. That's maybe the digestion portion is different from the Western people. But nowadays we eat lots of the McDonald's, so we are having the smaller, maybe the GA.
One question from the floor.
I don't know. I don't have any scientific evidence, but this way is actually the disadvantage, time consuming, because we can't take the grafts simultaneously. But for me, the important thing is for the patient for the long term. That's why I don't care about the time for taking down the graft.
One question from the floor, please.
Congratulations on the excellent work. Which is your criteria for arterial grafts, like the lesion, the percentage of the coronary lesion, like 70, 90, or whatever?
For the ITAs, I don't care about how much stenosis, but the GA does have a special indication. If the stenosis not tight enough, then the flow competition occurred. So the best candidate for using the GA is a total occlusion. But ITAs, I do like 75% the stenosis patient I use.
Hiroshi, thank you again, and again, congratulations on outstanding results.
Thank you very much.
So, which leads us to the last abstract, which will be presented by Dr. Chan, and it's about long-term survival after off-pump coronary artery bypass grafting in a high-volume center.
Good afternoon. Thank you very much for the opportunity for me to present my work. I have no disclosure other than this presentation is mostly all the Professor Angelini's story, so it's probably less scientific than the previous talks. When I joined the last 3 days, these are all the techniques that were shared. And one thing that struck me through particularly is the statement in the bottom. If we don't have a surgical site, there's no surgical site infection if we don't have a surgical site to start with. And this has changed myself as a resident a lot. But when I go back to the operating theatre tomorrow, we're going to perform stenotomy, mammary, and two-vein. The adoption of multi-arterial grafting and off-pump coronary artery bypass graft in the UK is progressively declining to approximately only 10%. But the question is, should we start tomorrow? And this is a talk to kind of summarize how we introduce off-pump in Bristol. And we also looked at the long-term survival across the 3 different phases, which we'll explain in a bit. Because if we don't look at long-term survival, no one else will. Not many of our surgical colleagues will, and it's not out of the interest of our cardiology colleagues to look at it, because they got a new toy every 2 years. What we have done is we looked at all the patients who underwent first-time elective or urgent coverage across 27 years at Bristol Heart Institute. We compare on-pump and off-pump and the long-term survival and in-hospital outcome. We divided into 3 phases, which I'll show you the volume in a second. The learning phase, when Professor Angelini brought this technique to Bristol. We then consolidating this technique. Again, I'll show you what he means by that. And after 2013, after new recruitment from external hospital, this technique is only performed by 3 out of 10 consultant surgeons. Statistical analysis was performed to match both groups using inverse probability treatment weighting. The data was asymmetric, that's why it's presented with median and interquartile range. And these are some of the statistical tests I have used. And this is the volume of what we have performed with on-pump and off-pump, with orange being on-pump. And as you can see in the early 2000s up to probably the early 2010s, off-pump is the most adopted technique. And after some retirement and external recruitment, the on-pump has taken over and it's now become the mainstream with a ratio of 2 to 1. The overall in-hospital outcome is similar with in-hospital mortality, deep sternal wound infection, and post-op requirement for dialysis, while there is a small improvement in stroke and return to theatre favoring off-pump. But looking at the learning phase, there is a very pronounced survival benefit for on-pump CABG. And this is what Prof. Angelini has told me. It's ungraftable, it's too small. And the rate of incomplete revascularization, according to data, which I won't show you, is shocking. For the off-pump is way higher than on-pump. And this is proven by one less distal anastomosis between off-pump and on-pump for all patients who had triple vessel coronary artery disease. And the second period where there is a consolidating phase, which I'll explain in the next slide. There is no difference between the two techniques, but what actually happened over this period is we improve as a team. We have anesthetists who sacrifice their coffee break to stabilize and allow us to sweep the heart. We have perfusionists who can play their phone, but they have to be on site, just in case for any conversion. And most of the time, they only turn on the CO2 for us. The scrub team preparing equipment, we have Octopus, intracoronary shunt. You don't need to ask. The size will be there, 1.5, 1.75 to. And the intensities recognize the benefit of off-pump and able to fast-track this patient to discharge them from ITU as soon as possible. And this allows us to have a survival benefit after 2013 when it's performed by the 3 dedicated coronary surgeons who still believe in this technique. But their story is we have introduced this service very well, but all 3 of them, including Prof. Angelini, and I hope the other surgeons are not here, one of them is common. If you have got a lifetime award, that means you are closing to your retirement age. Sorry, Professor Duckett. And in summary, I'm not here to argue whether on-pump and off-pump is a better technique. They can be both performed very well with very good results. But instead, I want to emphasize that introducing a new service requires time, dedication, and more importantly, it's more than the surgeon, is the team. And in our case, it took more than 15 years to see a survival benefit. Thank you very much.
Thank you for your excellent presentation. So I think what you showed in the 3 periods was that during the learning phase, on-pump was better than off-pump?
In terms of long-term survival, yes.
Yes. During the middle phase, the consolidation phase, there was no difference?
Yes, there's no difference.
And now in the final phase where you have 3 surgeons doing off-pump, there may even be a better outcome than on-pump?
Yes.
Why do you feel then that in the middle phase, where there seem to be real equipoise, why then did only 3 out of 10 surgeons persist with off-pump?
Well, I think that's a very challenging question to answer, and I think there's a lot of recruiting new surgeons and appointing new surgeons are complex, and as much as we looked at coronary surgery, we do have service for mitral valve and major aortic surgery, and those are often regarded as more important than adopting a new coronary surgeon that can quite often be regarded as anyone can do this operation. So a lot of focus in our department was to recruit mitral valve surgeon and major aortic surgeons.
Thank you.
Yeah, I think you raised an important point. My experience in my team when we went to the transition in Berlin was that there's still a number of surgeons who won't make the transition towards off-pump. And I cannot force them because you really have to want to do this. On the other hand, the young residents are trained in off-pump. So over time, the number of off-pump surgeries is just increasing. And I think you really need to have specialized surgeons to do it. Yeah. To maintain results. There's one more question and then we should, okay, sorry.
No, I want just to make a point. Beautiful presentation. I think that when we look at data on off-pump, one of the elements for which we don't have much data is neurocognitive dysfunction of these patients. Rate of depression, rate of ability to go back to normal life and normal mental skills. And I think this is very important, particularly in the world of aortic, and can make a difference in an era in which we are operating patients that are older, sicker, and with more comorbidities. Thank you.
So one more question.
Yeah, thank you. Franco Ciulli, I'm one of those 3 surgeons that have remained
Welcome.
diehard. So my view of this, brilliant presentation, but my view of this is volume. So each surgeon, each of those 3 surgeons are a high volume surgeon. And it's like mitral valve surgery. If you are in a center where you do high volume, high repair rate, you get good results. And Bolling has demonstrated that. And I think this is coming through this Congress as well. We talked about it yesterday as well. And I think it's the volume that's made the difference, because in the consolidation phase, there were surgeons that weren't doing 100% or 99% off pump.
Yeah. Thank you. May I ask you one final quick question?
Yeah.
In your final phase, where you have 3 surgeons doing off-pump and the others not, if you look at the baseline characteristics of that group of patients, are the off-pump patients higher risk than the on-pump?
From my personal experience and the data support that, we don't really have a selection. It's just whoever wait the longest, according to the manager, needs to be operated tomorrow. So sometimes you don't have a choice. So there is not much selection in terms of elective and urgent coverage.
Thank you.
At the end of the first session in which we judged the 4 best abstracts yesterday, we had unanimity among the judges. Today we have a split vote. Therefore, the majority vote, and I want to thank the presenters from Germany, Poland, Japan, and the UK. They all did a great job. They were all terrific presentations representing concerted efforts from their organizations to do high-quality coronary surgery, so we congratulate them all. Let's have a round of applause for all 4. The winner of this final is Maria Comenici, representing Dr. Raza, and the Hereford Group presenting 25-year follow-up. Maria, we'll have a $500 check for you in the mail. And congratulations again to Dr. Raza.